first of all, I will discuss the lesions over here, and then we are going to go towards the questions, right? And I won't be giving the answers to you. You have to tell me the answers at the end. Okay, now let's talk about the lesion. If there is a lesion below the medulla, now the DRG or preborder complex, they will not be able to send the signals to the inspiratory muscles, and the patient won't be able to respire if there is a lesion below the medulla, and that's why the respiration will stop and the patient will go in the respiratory arrest. Okay, if the lesion is below the pons and above the medulla, that is between the pons and medulla, now what will happen? Now understand, the patient will able to survive, it will able to respire or inspire and expire. Why? Because understand, there is no lesion below the medulla, the lesion is between the medulla and pons. Now the on-off center is present in the medulla, so whatever signals that are generated in the medulla, they will able to go towards the lung, and they will able to stimulate the eye neurons. So that's why eye neurons, and whenever the overdrive is there, e neurons also, and they are able to stimulate the inspiratory muscles and expiratory muscles. So that's why the respiration will occur. But remember, the respiration will not be regular. There is an irregularity will be present, and the respiration will be shallow, since the signals from the apneustic center, they are not coming towards the medulla because there is a lesion in between. Okay, so the respiration will be irregular and shallow if the lesion is at the level between the pons and medulla. Okay, then let's say there is a lesion. Let's say there is a lesion over here, that is the mid-pontine lesion. Now we have to consider two things: only mid-pontine lesion is there and the vagus is intact, or the mid-pontine lesion is there and with that the vagus is also cut. Okay, so let's say I'll write it over here separately about the mid-pontine lesion. So you have to be very careful when you discuss or you answer about the mid-pontine lesion, since the mid-pontine lesion is inhibiting the apneustic center, that is the pneumotaxic center is present in the upper pons. It is inhibiting the apneustic center, but understand there is another inhibitory signals that are also coming from the lungs, right? So we have to consider that also. Let's say mid-pontine lesion with vagus intact and mid-pontine lesion with bilateral vicotomy. Now, why I said bilateral vicotomy? Now, vicotomy means the vagus are cut, and we do have two lungs. From each lung, the one vagus is going towards the apneustic center, right? So that's why I wrote over here bilateral vicotomy. Now understand, if only mid-pontine lesion is there and vagus is intact, let's see the diagram. If only mid-pontine lesion is there and the vagus is intact, at least one inhibitory signal working properly. That means from the vagus the inhibitory signals are coming. The apneustic center will work more now. Why? Because only one inhibitory control is working on it and one inhibitory control is not working, that is PC is not working because of the mid-pontine lesion over here. What if the vagus is also gone? The pneumotaxic center is not able to inhibit the apneustic center, and we cut the bilateral vagus also. Now the vagus is also not able to inhibit the pneumotaxic center. Definitely there is no inhibitory control whatsoever on the apneustic center. The apneustic center will work all throughout, and definitely if there is no inhibition on apneustic center, it will cause something known as apneusis that we discussed. That is nothing but the inspiratory spasm. So if I have to write vagus intact and bilateral vicotomy, if the vagus intact, definitely at least one inhibitory center is working. So I will write that there is increase in the depth of respiration. There is a deep respiration is going to occur. Increase in the depth of respiration since the apneustic center is working more. Okay, but at least one inhibitory center is present. So I can write either deep respiration or increase in the depth of respiration. Now, if the bilateral vicotomy is there, now what is going to happen? If mid-pontine lesion with bilateral vicotomy, obviously it is going to go into the apneusis. the patient is going to go in the apneusis, that is nothing but the inspiratory spasm. The patient will land up into inspiratory spasm, which is again deadly, right? So no expiration will be able to occur over there. Okay, so that is about the lesion. Now, what if I ask you that the lesion is above pons? What will happen? Now, remember, above pons, we do have cortex, right? And in the beginning of the lecture, we will learn that the cortex is responsible for the voluntary control, right? Voluntary control, it is responsible. So obviously, if the lesion is below the cortex, the voluntary control will be gone. So there is no voluntary control, but the regulation will occur very, very smoothly without any problem, right? That is pneumotaxic center, apneustic center, and the medullary centers, they are intact. Okay, so smooth respiration will take place, but definitely the patient won't be able to have the voluntary control on the respiration if there is a lesion below the cortex or above the upper pons, that is above the pneumotaxic center. There is one more thing that we discuss in the respiration, that is something known as ondine curse. Now, what is ondine curse? There is something called as ondine curse. Now that is a curse. What if the pons and medulla, let's say there is a meningitis or any other infection or any other injury in which the pons and medulla, they're not able to send the signal. There is a lesion in the pons and medulla. Okay, if the pons and medullary centers, they are defective, they will not be able to send the signals to the lung muscles or respiratory muscles. The only way to respire, inspire and expire, that is the cortex via the cortical centers, right? So cortex is the only way, but the patient has to control his respiration voluntarily all the time. What is the problem? The problem is, as soon as patient goes in the sleep, there is no voluntary control possible during the sleep. So he will land up into apnea. Now understand, apnea and apneusis, both are two different things. Apneusis is the inspiratory spasm. On the other hand, apnea is temporary stoppage of breathing. So there is a stoppage of breathing. It can be into inspiration and it can be during expiratory phase also. So apneusis is different. Apnea is different. Apnea is stoppage of breathing. Okay. As soon as patient land up in the apnea after sleeping, he has to wake up, right? Because there is no oxygen coming, right? So the patient won't be able to sleep in this condition. That is known as the ondine curse, especially in the bulbar polio. If the patient is suffering from bulbar polio, definitely bulbar means brainstem, right? It is affecting the brainstem. Pons and medullary center, they won't be able to work over there. And in that condition, the cortex is the only way to survive. But the patient won't be able to survive for the longer time. Why? Because the death will occur that is not due to the respiratory causes. Remember, the cause of the death is lack of sleep. Lack of sleep. The patient won't be able to sleep. There are many sources which tell you that in the ondine curse, the death is because of apnea during the sleep. That is not the case. As soon as the apnea occurs, that is known as sleep apnea, the patient will wake up, right? Because the cortex is still working, the patient will wake up and he start breathing again and again. And the most common cause of death in those kind of patient is lack of sleep and not due to the respiratory causes. So that is about the ondine curse. Okay, so this is all about the neural regulation of respiration. Please remember the diagram. As soon as you remember the diagram and you remember how the things work over here, definitely you won't be having any problem in solving the lesions also. Okay, so I would like to give you the summary at the end. So this is the chart. You can take this screenshot of it. I hope you can see over here. I'll just discuss in briefly. So there is a neural control, right? We are discussing the neural control. So there are two types of control: automatic control and voluntary control. Voluntary means which is in our control, right? That is coming from the cortex, and two inputs, that is hypothalamus and limbic system, from where the voluntary control is going to take place. Plus, in the automatic control, we do have medullary centers and pontine center, who is the on-off switch. that is the medullary center, especially the DRG and the pre-Botzinger complex, which helps in the initiation of respiration. But the RAM signals and the eye neurons, they are present in the DRG only. Okay, then we do have VRG, which will have both the type of neuron, that is eye neurons and E neurons. The E neurons are especially present only and only in the VRG. So remember, please remember this mnemonic. It's very important mnemonic, DIVE. Okay, DI, that is GRG, contains only I type of neurons, and E type of neurons, they are only present in the VRG. VRG contains both the type of neurons, but E type of neurons only present in the VRG. Okay, so inspiration, over here inspiration and expiration, and this will be activated only and only during the overdrive phenomena. Then in the pontine centers, there is a pneumotaxic center and apneustic center. Pneumotaxic center is present in upper pons, apneustic center in the lower pons. Apneustic center, it causes the stimulation of DRG, I type of neurons. That's why prolonged inspiration. Pneumotaxic center, it prevents the apneusis via inhibiting the apneustic center, right, and it tunes the respiration properly and it maintains the rate. So depth is controlled by the apneustic center and rate is controlled by the pneumotaxic center. And you can see over here prolonged inspiration, so the apneustic center, it is going to go and stimulate the DRG and causing the quiet inspiration. Okay, that's all about the discussion. Now let's come to the MCQ part, and I would love to see your answers in the comment box below. If you want the discussion, we can discuss that again, but I hope the discussion which we had already on the neural regulation of respiration topic, it is sufficient to give you the answer, right? First question is, respiratory control centers are located in midbrain and medulla. Option B, medulla and pons. Option C, pons and midbrain. And D, upper spinal cord and medulla. Please give the answer. Let's move on to the next question. Damage to pneumotaxic center results in. They're asking about the pneumotaxic center. If it is damaged, what is going to happen? Decrease of inspiration, increased depth of inspiration, increased depth of expiration, or decreased depth of expiration. Let's move on to the third question. Stimulation of reticular activating system of the brainstem plays what role in ventilation? Stimulate ventilation, inhibits ventilation, stimulate inhalation but inhibits exhalation, that is apneustic breathing, and stimulate exhalation but inhibits the inhalation. Now, about the RAS system, I would like to give you a hint, that is RAS system is activated when you have to be very, very alert, active. It's kind of when you're under a stressful situation, the sympathetic system will be activated and this RAS will be activated. Now, what will happen if you're under a stressful situation or you need the extra amount of respiration? Please let me know in the comments below. Then question number 4, destruction of which part abolishes automatic respiration? A, pre-Botzinger complex. B, ventral group of respiratory neurons. C, section at superior border of the pons, and D, section at the inferior border. So these are the questions, MCQs. I would love to see your responses in the comments, right? And definitely yes, after some time I'll be giving the answers to these questions also in the next video. Okay, till that time, keep studying, stay healthy and enjoy the life. I hope you like the video. Let me know in the comments. Bye bye.